Right. Okay. Welcome everybody to this cardiac transplantation and circulatory support session. My co-chairs in the session is Mr. Stephen Clark, Mr. Mas Corsandi. I am George Mascaro, and Andreas Zuckerman joins us from Austria as well. So we hopefully are going to have a very interesting session, which everybody is going to enjoy, and we have very interesting topics. I'm going to start by introducing the first presenter, Dr. Bokshi, who is going to talk about surgical palpation to exclude donor-transmitted coronary artery disease, a single-center experience. Dr. Bokshi, you are online.
Ladies and gentlemen, thank you for attending my talk on assessment of donor-transmitted coronary artery disease. As you may know, coronary artery vasculopathy causes significant comorbidity and mortality post-heart transplantation. The 2020 consensus statement recommends coronary angiography in potential heart donors with risk factors for coronary disease, including those aged over 40. In the UK, coronary angiography for offered donor hearts is seldom available. The presence of coronary disease is assessed at the time of procurement by the surgeon via palpation of the coronary arteries. The exact accuracy and reliability of this assessment is not known, and the assessment is limited to the main coronary arteries, which can be palpated. Here, we examined the incidence of donor-transmitted disease on our cohort of patients and its impact on the long-term survival. We included all patients who had undergone isolated heart transplants over the 11-year period from 2008 until 2018. All patients who had undergone angiographic surveillance for coronary artery disease were included. We included both left heart catheterization and CT coronary angiograms. All angiograms were examined and graded by 2 observers independently, and any discrepancies were checked by a 3rd observer to ensure accurate grading. The coronary angiograms were graded according to the ISHLT nomenclature, grade 0 being no lesions, grade 1 mild disease, grade 2 moderate disease, and grade 3 severe disease. I will not go into the details of the definitions, but they can be seen here on the slides. We define significant coronary artery disease as any evidence of grade 2 or 3 coronary artery vasculopathy, or grade 1 with focal lesion of greater than 50% in the main coronary artery. These angiograms depict examples from each grading. And here are examples of patients with grade 2 and 3 coronary artery vasculopathy. Over the 11-year period, 389 heart transplants were performed. Of these, 309 had angiograms performed post-transplant. A further 7 were excluded due to no donor data being available. In total, 302 met inclusion criteria and were included in the study. The average donor age was 38.2 years, and the average recipient age was 48.8 years, with the majority of the patients being male. In our cohort as a whole, 9% of the patients had evidence of donor-transmitted coronary artery disease. This was associated with a significant reduction in long-term survival, as demonstrated here by the Kaplan-Meier graph. We then looked at various risk factors which may lead to increased donor-transmitted coronary artery disease, including diabetes, hypertension, smoking history, as well as the donor age. We separated them into 2 groups of donors greater than 40 years old and donors of 40 and under. There was no significant difference between donor-transmitted coronary artery disease in hearts that came from donors over the age of 40. Also, in the same group, isolated risk factors did not seem to be associated with increased risk of donor-transmitted coronary artery disease. However, the presence of 2 or more risk factors in donor hearts over the age of 40 was associated with a significant increase in the risk of donor-transmitted coronary artery disease. This was not visible with donors under the age of 40. Donor sex, BMI, and CMV mismatch did not seem to have the same effect. In conclusion, here we show that donor-transmitted coronary artery disease leads to significant reduction in long-term survival following heart transplantation. Donor age of greater than 40 alone does not seem to predict donor coronary artery disease. However, high donor age, when combined with 2 or more risk factors, is associated with an increased risk in donor-transmitted coronary disease. In such situations, surgical palpation alone is insufficient in predicting disease, and coronary imaging may be indicated to exclude donor coronary disease. Thank you for listening.
Hello. Should there be questions, answers now or at the end of the session?
Now.
So may I start? May I start the question? Very, very interesting. For me, a question is, so if you do not have a lot of angiographies performed prior to procurement, do you know what is the number of donor hearts that are rejected on the table due to coronary artery disease? Do you have a number on that too?
Hello, sorry, I can't hear the question.
In donors where the procurement team went out, and of those who were rejected on the table during the procurement, do you know the number of those that were rejected due to coronary artery disease? Or what is the rate of rejection on the table in the UK? While you do the procurement?
I don't have that data because the procurement is done by the various teams across the country. So I don't have the exact data on how many hearts have been turned down because of palpation of coronary disease.
Okay, thank you.
I think if I may make a comment in that regard, our central organization, NHSBT, does have probably some data on that. I don't have the numbers at stake at the moment, but it is a significant number of hearts that is being turned down because of palpable coronary artery disease. I was just going to ask Mr. Vokshi if all those transplanted hearts were patients where coronary artery disease was not detected at the time of inspection, I presume. Is that correct?
I'm sorry, my connection is really bad. I didn't hear the whole question.
Those patients that were transplanted, all of them didn't have any coronary artery disease. Is that correct? At retrieval, at the time of retrieval.
None of those showed any evidence of coronary disease that was palpable, if that was your question.
Okay, yeah, that was the question. Thank you very much. Thanks. Mas, would you like to introduce the next speaker? Okay. Stephen, can you hear me? Would you like to introduce the next speaker? Okay, the next presentation is Dr. Chilvers, who will talk about cardiopulmonary transplant surgery, a bedtime story. Dr. Chilvers.
Good afternoon. My name is Nick Chilvers and I'm from the Freeman Hospital in Newcastle. Thank you for the opportunity to give this presentation, Cardiopulmonary Transplant Surgery, a Bedtime Story, and I hope you can stay awake for the duration of this short talk. We have no conflicts of interest. We are conscious that transplant activity normally happens out of hours. More and more, we are appreciating the impact of human factors in healthcare, and in particular the effect that fatigue has on technical ability and patient safety. We sought to investigate this in our centre's transplant programme. We used a few applications and programmes across a period of 43 working weeks. We used Apple iWatch Sleepwatch software that provides continuous sleep monitoring, and this generates logs of sleep time, heart rate, and heart rate variability. The Childer Fatigue Scale was used as a measure of assessing the extent and severity of perceived fatigue. And we looked at dexterity on waking using the Kando dexterity test. Analysis was performed using the unpaired t-test. The results showed that during the 43-week period, 241 nights were spent off duty, 23 required the consultant to come into the hospital during their on-call, and 37 on-call nights were spent at home receiving phone calls. Median disruptions were significantly more on nights when the consultant had to come into the hospital, with 7.1 disruptions. Sleep initiation also took longer, and total sleep time was reduced on nights when they were on call. Indeed, for on-call nights requiring return to the hospital, the average sleep time was just 3 hours and 20 minutes, and unsurprisingly, the overall amount of restful sleep was also less. Average heart rate was the same between the two groups. However, we saw a decrease in heart rate variability, which is known to be associated with adverse health effects. Tracing accuracy and dexterity scores were worse, and reaction time significantly longer after nights spent on call. Perhaps the most concerning finding was with the Childer analysis of perceived fatigue. There was no statistically significant differences between being on call and attending the hospital or not, and not being on call. The surgeon was simply unaware of the effects that this fatigue was having upon them. So in conclusion, on-call rotas have profound effects on sleep, and this is significant whether the consultant is called into the hospital or not. It is associated with a loss of heart rate variability, which is known to have adverse health effects. The objective reduced dexterity and increased reaction times as a result of fatigue are really quite concerning. However, more worryingly, Childer analysis suggests a lack of awareness by the surgeon on the effects of sleep deprivation, particularly on their technical skills, at a time when patient safety during complex operations is paramount. We believe that further study is urgently warranted on the health effects of transplant on-call rotas for surgeons, the effects of fatigue on technical ability and patient safety, as surgeons seem unaware of these objectively measured and concerning effects. Actually, we perhaps need to rethink some of the on-call models to ensure that surgeons aren't facing complex tasks, having been recently on call. In doing so, hopefully we can mitigate some of these risks. Thank you for listening to my presentation, and I look forward to taking any questions that you might have.
Well said. The point is, who should do this business now? I'm doing in-hospital shifts for 30 years now, and I completely agree. I hate it because you never sleep well in the hospital, even if they allow you to sleep at some point. But the question is, how can we change this? Is there anything that could be done? Somebody has to take these calls, or? Cannot hear anything.
Hello?
Can't hear anything.
Can you hear me?
Do you?
I'm
Can you hear
very
me now?
sorry if you can hear me. I can't hear any audio back.
Okay.
Can you guys hear me?
Yeah, we can hear you, Mas.
Yeah, I just wanted to make a statement here as well. I think it was a great presentation, and Nicholas, if you can't hear us, I guess if you can hear us, can you hear us, Nicholas? I don't think you can hear us. But I just wanted to make a statement. I currently work in the United States, and there's move towards doing these especially high-risk transplants during daytime hours, and setting up procurement
I'm very
times.
sorry. I don't know if it's a Newcastle connection, but myself and Prof could hear the presentations, but unfortunately I can't hear any of the questions from the moderators, and I do apologise for that. I think others have struggled as well.
Yeah, I don't know how to mitigate to that. I mean, there's been moved
if
towards...
If anyone has any typed questions, I'd be more than happy to try and answer them.
This session is not going as smoothly as we thought.
Keep going, Mas.
Yeah, so we've moved towards doing this, adjusting the time of these procurements so that we do these transplants, especially the VAD explants, and the multiple redo operations during daytime hours. So I don't know if that's going to also happen in Europe. I hope it does. But there's definitely been a move towards that, I feel.
Yeah.
So I think one of ways of doing it, yeah. Mm-hmm.
No, just one of the issues here in the UK is that we are very much dependent of the abdominal retrieval teams. Actually, we normally the cardiothoracic teams, they revolve around the timings of the abdominal retrieval teams. So it's much more difficult probably to make it a daytime activity rather than whatever time activity it is.
Yeah. I mean, it's certainly not easy that, especially in a healthcare system like the U.S. with elective operations bringing so much money, the transplant procurements are always trumped to the middle of the night. So it's definitely an issue.
Yeah. Okay, I think in the I can't see any questions in the in the question and from the audience. There is only an old question, for the previous presentation there, that asks what are the restrictions for donor coronary angiograms in the UK. And if I can answer that, is that in the UK, donors are not required to have a coronary angiogram. That's the main reason. Okay, in the interest of time, I think we'll move to the next presentation.
Do you want me to introduce the next presenter?
Please do. Yes, please.
So, the next presenter is to introduce. Do I need to go to the next screen, or do I need to go to the presentation screen, or can I present? No,
just present. Just present, and then it will.
It will move towards the next one. Okay. So the next presentation is the 3-dimensional printed lung thorax models and aid to lung transplant size matching in fibrotic lung disease by S.B. Trochbin.
Distinguished members, ladies and gentlemen, Thank you for the opportunity to present this proof of concept experiment in lung transplantation, where a 3D printed thoracic model is used as an aid to lung transplant size matching in fibrotic recipients. Before I start, I would like to thank the faculty at the St. George's University in West Indies, especially the medical students and the medical illustrators, without whom this project would not have taken off the ground. As we know, patients with interstitial lung fibrosis have a small chest cavity. The CT scan illustrates the chronic pathology that leads to the discrepancy between the actual and the predicted lung volume that makes the accurate size matching of donor lungs to recipient quite challenging. So donor recipient size matching heavily relies on clinical judgment and experience, and the current objective measures alone are not sufficient. We know that under and oversizing the lung is associated with poor clinical outcome, and therefore we have created this 3D prototype as a subjective aid in size matching specific to the patient to facilitate lung procurement. So our objective is to produce a patient-specific 3D model of a recipient lung and thorax for patients with interstitial lung fibrosis awaiting lung transplantation. And the way we do that is by the recipient CT scan are subjected to data transformation to produce a 3D printing file and then printed. A mold of an anterior and posterior halves of the lung are created to replicate the patient's thorax. And finally, the 3D print is sterilized and taken to procurement to aid on-site size matching of donor and recipient lungs. This is the way the lung sits within the base of the model and is covered with a transparent lid. So the model in its entirety composes of a three-dimensional base, a three-dimensional lung with three-dimensional pins connecting 4 different pieces together, and that is covered with a transparent lid. At this point, it is important to mention that special consideration was given when creating these modules to ensure that lungs, when inside the tray, would not be pinched or compressed. This slide illustrates the software use in a bit more detail. However, this is where we are at the moment. We have successfully produced a small-scale model of a lung which could be sterilized. The next stage would be to produce a full-scale lung module. So we really believe that this real-time comparison using this model adds another dimension to make the assessment of lung volume more accurate. We also believe that this subjective assessment supplements the largely objective lung volume measurements currently available. This tool helps the surgeon decide whether to perform lung volume reduction surgery on the donor lung or whether to simply offer the lung to another patient or another center. There have been challenges throughout this project, mainly with the software. However, the main challenge has been COVID-19 pandemic, which have dramatically reduced the lung transplantation worldwide and has caused delays in our project, in our production line. I thank you.
Thank you very much for that presentation. I don't know if there is no questions from the auditorium. I don't know if there is any questions from the panelists.
Very nice presentation, Speed. Does that only apply? Did you only apply that to IPF, or is it also applied to the other conditions?
Hi, Matt.
COPD.
Thanks very much for your question. I think the issue with IPF is that there is no good way of actually assessing size for IPF. There's not much evidence on how best to size match donors to recipient. And that is what is causing the challenge, actually. And we thought of using this mainly subjective measure in addition to the objective measures which currently we use, which are not perfect.
Yeah, it was definitely very helpful. And
yeah.
I mean, the other thing is that it's easier for us to try to measure lung volumes for example, patients with COPD or cystics or pulmonary hypertension. But I think the challenge with the IPF is that the lung, this chronic change that I was mentioning in the lung that happens, the shrinkage, causes such a big discrepancy between the actual and the predicted lung volumes that we need to have a little bit more, some better measurement than just the objective measures that's currently available, namely the radiological and the physiological things that we have to hand.
Yeah, and for IPF, do you normally do SOLT? Is it single lung transplant? Is that basically it?
We haven't done a lot of single lung transplants in the recent years, and because we think that the outcomes are better with double lung transplantation, although we know that there is a issue with donation, and so we have done occasionally single lung in the IPF as well, and we don't exclude single lung, but most cases we use double lung.
Got it. Thank you.
Thanks,
Speed, very good presentation. Can I ask you, have you correlated this with the other ways of estimating lung volumes, like CT scans and all that sort of new ways of reconstructing?
Yes, thank you, Mr. Mascara. Very good question. This actually, we do use CT scan very heavily in this. So what I couldn't go into detail during this presentation was how we actually retract these from the CT images, the DICOM images out from CT scan. So what we start with is a CT scan of these patients with fibrotic lung disease, and then we do reconstruction of those in the DICOM imaging, and then we go on to use different technical computerized imagery in order to get our 3D image.
Okay, thank you very much, Speed. I think we are being pressed to carry on in the interest of time. Steve, do you want to present the next speaker, if you must?
Yeah, next speaker is also a friend of mine. impact of donor and recipient age on 5-year survival following heart transplantation, a 24-year national analysis from the United Kingdom by Jason Ali. Jason?
Thank you for the opportunity to speak. I would like to present our work looking to examine the impact of donor and recipient age on 5-year survival following heart transplantation in the UK. With advances that have taken place in the medical management of patients suffering with end-stage heart failure, patients are presenting for transplantation at a later age. And similarly, with an aging population that we see, the average age of potential donors has also been increasing over recent years. The impact of donor and recipient age on outcomes following heart transplantation remains controversial. So the aim of our work was to examine the impact of donor and recipient age on 5-year survival following heart transplantation in the UK. We've reviewed all patients undergoing heart transplantation over a 25-year period in the UK. We included all patients aged over 18, undergoing first-time DBD heart transplantation at one of the 6 currently active heart transplant centres. Over the period of study, 3,304 patients underwent heart transplantation, with a 1-year survival of 80.9% and a 5-year survival of 70.1%. As anticipated, over the period of study, we see an increase in the average age of recipients, and similarly, an increase over the 25 years in the average age of the donors. Examining 5-year survival of the recipients, categorizing donors and recipients into 3 age strata, we see that both donor and recipient age appear to be significantly associated with an inferior survival following heart transplantation. If we impose 90-day conditional survival, the impact of recipient age on survival is lost, and the impact of donor age almost becomes insignificant. To take this work forward, though, we utilised previous studies by the NHSBT that have demonstrated 9 variables that are known to impact negatively on survival following heart transplantation. These include donor cause of death, donor and recipient BMI, recipient creatinine, VAD status, primary cardiac pathology, cold ischemic time, sex mismatch, and the use of machine perfusion. Using these 9 variables to risk adjust survival, we see that recipient age appears no longer to be significantly associated with inferior survival. In contrast, donor age retains its significance as an independent predictor of inferior 5-year survival following heart transplantation. However, looking at 90-day conditional survival, there is no longer this significance, suggesting that the impact of donor age is focused on the early postoperative period. Recipients receiving older donors, if they survive through the perioperative period, there appears to be no significant impact on their survival. Taking this one step further, using those 9 variables known to impact on the UK transplant outcomes, we divided our cohort into 3 groups, depending on the number of variables adversely affecting outcomes that they possess. And interestingly, what we see is that the risk-adjusted impact of donor age on recipient 5-year survival is statistically significant only for the high-risk group, suggesting that the impact of donor age is most pronounced in donor-recipient combinations possessing other variables impacting on inferior long-term survival. So in conclusion, we see that recipient age appears not to impact on 5-year survival following heart transplantation. In contrast, though, donor age does appear to be an independent predictor of inferior risk-adjusted 5-year survival. Specifically, what we see is that the impact of donor age is focused on the early postoperative outcome, perhaps related to the higher incidence of delayed graft function. But additionally, the greatest impact is seen on those donor-recipient combinations with other risk factors for adverse outcomes. Thank you.
I'm being told that he is not, that Jason is not with us in the within the panelists. But before we go to the next presentation, I would like to ask Mas and Andreas, do you do any matching, age matching between donor and recipients?
Mas,
Yes. I started here at the University of Washington in August, and we have been, me and my partner, we both started together, and we've been rather conservative to start with in terms of our donor selection. We don't have in the United States, unlike the UK, an issue as such regarding the number of donors. There's like the opium epidemic here. There's tons of gun violence, people driving crazy, and so there are lots of donors to go around. We've been very conservative. We've been sort of erring on the side of caution when choosing donors over the age of 40. And if we do choose donors over the age of 40, we've been asking for coronary angiogram, echo, a detailed echocardiogram, sometimes even a transesophageal echo, and sometimes a right heart cath before proceeding to taking those hearts. So we've been very conservative in that regard. But yeah, it's certainly is very obviously a known cause of PGD is an advanced donor age. It also is known to also advanced recipient ages has been attributed in the past in various studies to the rate of PGD and poorer outcomes. One thing I have to say about this Jason's presentation, though. I think there are lots of factors that could confound this result. For example, if you have a patient who has a VAD, has got extremely high PA pressures and stuff like that. I don't know if those patients were adjusted for in this study because there's lots of variability amongst the recipients, so they're not uniform.
Okay.
So that's one thing I have to say.
Okay. Thank you very much. Andreas, do you want to say something? Needs to be
very, very quick. We try to match, but normally it does not work out because the median age of the donors is 45 years. So we normally cannot match.
Is what's happening with us as well. Okay, we're going to move quick to the next presentation. I'm going to present it. It's a pediatric heart transplantation following donation after circulatory death, distant procurement, and ex situ perfusion by Eyal Ran Nashum.
Good morning. My name is Eyal Nahum, and I'm pleased to present the joint unique experience of Popov and Great Ormond Street in pediatric heart transplant following donation after circulatory death. Pediatric heart transplant is considered to be the treatment of choice for children with medically refractory end-stage heart failure. As we all know, there is significant shortage of organs for children listed for heart transplant, which reflects in this graph with an increase in pediatric patients on the waiting list during the last decade in UK. Evidently, the pediatric waiting list mortality is unacceptable high. In gauche, we had a decrease in the number of pediatric heart transplants in general, and specifically in 2019, we did only 2 pediatric heart transplants for recipients who weighed more than 20 kilos. Donation after circulatory death increases the number of organs available for transplant. In 2015, we and Popov commenced our own program in adult DCD heart transplant following the success of the abdominal transplant DCD program. Reviewing our 5 years experience, the adult DCD program increased heart transplant activity by almost 50%. Importantly, we demonstrated similar outcomes between matched DCD and DBD cohorts with respect to survival, ICU, and hospital stay. This impressive result, with the lack of enough pediatric donor hearts, inspired the initiation of pediatric DCD program here in the UK. We aim to assess if we can translate the success in adult DCD program to a DCD pediatric program. We reviewed retrospectively all the DCD pediatric heart transplant in gauche in between February 2020 and June 2020. The organs were retrieved by the Popov retrieval team and transported to Great Ormond Street for implantation. We utilized a direct procurement approach for organ retrieval. Following donor declaration of death and 5-minute standoff time, the donor heart was retrieved in rapid sequence. Then the hearts were mounted, reanimated, and perfused on an egg-sided perfusion platform. We are currently using the Transmedic organ care system. On the OCS, the hearts can be assessed in real time. The parameters include visual assessment of contractility, anatropic requirements, mean arterial pressure, and trends in venous and arterial lactate levels. Following a quick initial assessment, the organs were transported to gauche on the OCS with ongoing assessment. Due to technical limitation of the OCS, only hearts from a donor who weighs above 50 kg are fit to be perfused on the OCS. Accordingly, the gauche transplant team approached and consented for DCD listing only all families of children over 20 kg. Our series include 5 children who received a DCD heart. The median age of the donor was 19, 3 of the donors were male, the mean weight was 61 kg. The median recipient's age was 13, the mean weight was 35 kg, and similar to the donor group, 3 of the recipients were male. 2 of the recipients had a previous cardiac surgery. 1 had undergone heart transplantation and the other LVAD implantation. Warm ischemic time is defined as a time from donor asystole to commencement of perfusion on the OCS. The mean warm ischemic time was 25 minutes. The mean travel distance was 150 miles, and the mean excital perfusion time was 266 minutes. As expected from suitable hearts, during the excital perfusion, the lactate levels have progressively decreased in both arterial and venous sample. None of the recipients required postoperative mechanical support. The median ITU stay was 8 days, and the median total hospital stay was 16 days. All recipients were discharged home. Pre-discharge echocardiography showed good biventricular function in 4 recipients. 1 recipient demonstrated moderate RV dysfunction, but recent echocardiographic follow-up demonstrated good biventricular function in all recipients. In conclusion, with the DCD program, we nearly doubled the heart transplant activity in Great Ormond Street during this period of time. In our small series with short-term follow-up, the use of a DCD heart for pediatric heart transplant seems to be safe and has an excellent short-term outcomes. Regarding the OCS, it seems that it provides good myocardial protection even with distantly procured orthotopic hearts. And finally, the development of the DCD program to include the use of smaller organs should be a priority for both units. Thank you very much.
Thank you very much for that presentation. Any comments?
Great work. So congratulations. I think it's time that DCD moves also to the pediatric population. I think it makes absolutely sense. For me, the big question is, shouldn't we try to work to find a way to procure also smaller DCD pediatric hearts, maybe to adapt the organ care system?
I think, Eyal? Do you want to reply to that?
Yeah, do you hear me?
Yeah.
Yeah, so I think it's a good time, but as I mentioned, the main problem is the limitation of the OCS machine, that we have a limitation of 50 kilos. So I know currently that there are few machines that are developed in order to support smaller hearts, and we will be quite happy to start using smaller hearts on these machines and to start retrieving smaller hearts as a DCD.
Yeah. Thanks. I don't think there is any questions in the audience at the moment. Any other comments? Mas, do you want to present next speaker?
Sure. Next speaker is Vishal Pengal, Transmedics Organ Care System in Heart Transplantation for Congenital. No, sorry, no, that's the, sorry, wrong order. Extending the role of the transplant practitioner within the NORSE as organ care practitioner, Francisco Olano.
Hello everyone. Thank you all for attending this session. My name is Kiko Olano and I am a transplant practitioner at the Royal Popworth Hospital in Cambridge. I am here with you today to discuss the topic about extending the role of the transplant practitioner within the National Organ Retrieval Service to include organ care practitioner. So let me begin by introducing to you the obligatory members of the National Organ Retrieval Service, or the NORSE team at the Royal Popworth Hospital. On the left is a picture of our team when we have taken up to what was called the Tetris Challenge, which gone viral in social media back in 2019, highlighting the huge amount of equipment that we need to do our job and how it fits into our relatively small vehicle. NORSE is a commissioned group led by an NHSBT competent lead surgeon that performs organ retrieval, a donor care physiologist or DCP who is a healthcare professional that maintains optimal organ function prior to and during the retrieval process. We also have a scrub or theater practitioner who provides expert assistance to the surgical team in theaters. And the last but certainly not the least is the transplant practitioner. So altogether, we comprise the cardiothoracic NORSE team at the Royal Popworth Hospital. Before I tell you more about the job role of the TP, let me give you a quick background of the job. So the transplant practitioner is officially known as the organ preservation practitioner. When not on call or not out on retrieval, we play our role as the transplant specialist nurse within the transplant continuing care unit at the Royal Popworth Hospital. So this is fundamentally our day job. At present, we have 6 transplant practitioners, both band 5 and 6, and 2 of our nurses are currently in training. Moving on, here is an outline of the role of the TP. During organ procurement at the donor hospital, our main responsibility is to preserve, perfuse, and pack cardiothoracic organs in cold storage, which is also known as the glorified ice box. We also ensure that HTA forms are accurately filled out before dispatching the organ to the respective transplant center. The OCS machine, or the heart in a box as we all know it, is a portable ex vivo organ perfusion system which continuously monitors the heart from the moment of instrumentation, during transit, and up until it's disconnected for transplantation at the recipient center. This machine is usually being operated by a surgical fellow or a donor care physiologist. But because of the staff shortfall and the increase of DCD heart transplant activity, the extension of the role of the TP to include organ care practitioner has emerged, which means that we can also operate the perfusion machine independently ourselves. Various methods of training were launched to ensure additional competency is developed. Along with other surgical colleagues, we were given the opportunity to travel to Boston, Massachusetts, in the United States in 2019, to undertake a week-long training in order to operate the machine effectively and safely. In addition, in-house training, shadowing colleagues were also initiated by other competent members of the NORSE team. Debriefing and personal reflection were somehow indispensable in order to achieve confidence and competence in operating the machine. There is a competency pack that we have to complete towards the end of the training for us to be deemed proficient and competent. So this advanced skill has allowed the TP to progress in the role, and more importantly, has allowed our center to be fit for purpose, especially prior to the introduction of the National DCD Heart Retrieval Service last year. So we used to just retrieve hearts for ourselves, but now with this UK-wide DCD Heart Retrieval program, we can do it with any other transplant center. So this is definitely a game changer. There has been a significant drop of donors and transplant activity during this was introduced in the midst of the coronavirus pandemic. So as of this writing, 4 machine-perfused hearts out of 6 organ retrievals that were operated by ATP were successfully transplanted. However, we expect that this number will rise post-Rona. To conclude, the extended role of the transplant practitioner, both as organ preservation and organ care practitioner, has proven to be effective in order to ensure that non-medics like me are also equally capable in operating specialized machines such as the OCS. And ultimately, it ensures that our North Team resilience is maintained. Thank you all for listening.
Here at the moment. So we're going to jump straight away to the next presentation by Vishal Pingle, which is, am I okay? Yeah, by Vishal Pingle, Transmedics Organ Care System in Heart Transplantation for Congenital Heart Disease.
Good afternoon, I'm Vishal Pingle. Greetings from Newcastle Freeman Hospital. This is the data from NHSBT showing the cardiothoracic transplant activity. The number of patients on the active list is still increasing despite the enormous efforts by all the centers. DCD donors offer some hope to expand the donor pool. Ex vivo perfusion is an indispensable part of DCD heart transplants. There are numerous studies on the use of OCS. However, there are hardly any studies on the use of OCS in adult congenital heart disease. If we look into these studies, actually PROTECT 1 and PROCEED 1 excluded patients with adult congenital heart disease. PROCEED 2 had very small representation of congenital heart disease. One might argue that if OCS works in adult patients, it should also work in adults with congenital heart disease. Unfortunately, there are no studies to demonstrate that. Patients with adult congenital heart disease need heart transplant at younger age. There are multiple surgical problems. Not just the surgical problems, even the outcomes are a bit different, as very well published in 2014 Journal of Heart and Lung Transplant. The survival post-transplant in TGA patients is 88%, while in AV canal defects, it's 62%. The in-hospital mortality is almost 23% in single ventricle physiology. Even in perioperative period, the need for dialysis is almost double the patients without congenital heart disease. If we look into the reasons for mortality, primary graft failure and multi-organ failure is twice as common as in patients without congenital heart disease. So we decided to look into our own data. We did a retrospective review of all our adult patients with congenital heart disease in whom OCS was used as organ preservation technique. We had 11 such patients. In all the patients, the OCS was used as prolonged transportation time was anticipated. Just as in most of the adult congenital patients, our patients also had multiple surgeries, as listed below. One patient underwent combined heart and liver transplant. We looked into the OCS time, the start, peak, and the base lactate levels for all the patients. The average number of previous cardiac surgeries was 4. The mean OCS perfusion time was 357 minutes, with shortest being 194 minutes and the longest being 916 minutes. The mean OCS time was 298 minutes in survivors and 515 minutes in non-survivors. 3 patients required ECMO, 2 had primary graft failure, and 1 developed pulmonary edema from the aortopulmonary collaterals. One of the patients with primary graft failure recovered well. There was no obvious increase in the need for inotropes. The mean peak lactate was 3.3 in survivors and 3.6 in non-survivors. We had 3 in-hospital mortalities, of which 2 were within 30 days of the transplant. So we had a 30-day survival of 72.27%. Going through the mortalities, the first mortality was the patient who had left ventricular assist device post-Sennings repair. As all VAD have difficult expand, he also had a difficult expand. He also had access issues complicated by bilateral iliac stenosis. He had profuse bleeding from the raw surface and was complicated by primary graft dysfunction, for which he was put on ECMO. The second one was post-Fontan with multiple arteriovenous malformations. He had embolization done prior to surgery, but unfortunately he had pulmonary hematoma from the collaterals and failed to wean from the bypass. The last one was the post-VSD repair who had multiple interventions for mitral and tricuspid. He was listed as a supra-urgent. He had primary graft failure. He required ECMO post-transplant. He recovered well and was weaned off ECMO. Unfortunately, he died 3 months later of sepsis while he was still in hospital. He's the one who had long OCS time of 916 minutes, which caused a bit of distortion in our results, but we still included him as it was a post-surgical complication. So, in conclusion, the study does not demonstrate any correlation between OCS time and the poor outcome. There was no correlation between the peak lactate and the death. OCS does not adversely affect the outcome in adult patients with congenital heart disease. Thank you.
Are there comments or questions from the moderators? For Vishal.
A question. Well, it's more of a statement, I think. So I guess, there's no doubt that OCS is great in preserving the heart, but I think a lot of the PGD and stuff you experience, do you think that has a lot to do with the recipients rather than with the way the heart is preserved, with, complex fontans and whatnot, and the new donor heart is going into in a very hostile environment that's likely to require, extensive dissection to explant the native heart, and then you require a lot of blood transfusion that leads to, the donor heart failure and PGD.
I think, that's a very well pointed out by you. So that's the reason I pointed out that these patients require multiple transfusions because of bleeding. That increases the risk of PGD. Surprisingly, in our study, the patients who had PGD, one of them had OCS only for 190 minutes, and the other one had for 900 minutes. So we can't actually say whether OCS or prolonged time on OCS is actually the reason for PGD. I know this is a very small study to conclude that, but what we saw, it's more related to the recipient rather than the donor and the OCS.
May I briefly jump in just to comment? When you look at the consensus paper on PGD published by John Kopashigawa, myself, Peter McDonald, and others, there's a clear distinction between primary graft dysfunction that's really just donor associated, where most of the times you just do not know why it happens. And you have a secondary graft dysfunction that's always mixed up, and secondary graft dysfunction is where you find a clear reason why this heart suffers. And exactly what you said, polytransfusions, bleeding, and all of that. You can give the perfect heart into these patients, and still these hearts struggle. So be careful to call it primary graft dysfunction, because the reason is not it was perfectly well preserved by the OCS or whatever technology you use, But as you said, Mas, very correctly, the hostile environment of this very bad recipient really let the heart fail. And this is something you have to be careful to say whether it's PGD and then say, oh, that's the OCS that produced the PGD. It's not true. It's the hostile environment of the recipient. I think this is very important to distinguish these two entities of graft dysfunction. Just a comment, but great talk. Thanks.
Yeah, good point. Good point. Okay, we move on then in that case, and the next presentation is in charge of Bianca Lord, who's going to talk about pediatric organ retrieval and the emotional impact this has on the National Organ Retrieval Service team members.
Hello, I'm Bianca Lord, and I'm going to be talking about pediatric organ retrieval and the emotional impact this has on the NORS team members. My background is transplant nursing, and I have been working in the organ perfusion role at Royal Papworth Hospital for over 7 years now. In my experience of organ retrieval, there are specific cases that still resonate with me, but more emotionally pediatric cases. Although it is an honor carrying out a family's wish of organ donation, which can help in many ways with the transplant, the retrievals are emotionally challenging and remain infrequent, and therefore staff are less exposed. The aim of this work was to establish how staff cope and what supportive practices could be put in place, acknowledging the emotional impact that pediatric retrievals cause. I desired a survey, which I sent out to the Papworth NORS team, asking them 7 questions relating to pediatric organ retrieval. The survey results are as follows. So there were 22 respondents from Papworth NORS team. So surgeons, DCPs, squad nurses, and OPPs for perfusion role, within the perfusion role. Looking into experience, 69% of respondents had only been to 1 or 1 to 3 pediatric retrievals, which shows this a frequency, and very few, so the minority of respondents have been to more than 10 pediatric retrievals. When asked about a difficult occasion, the majority, or 90% of the respondents stated that all these are emotionally challenging and stated a number of reasons. Some team members mentioned things like age, circumstances, and the size of the donor organs. It was difficult to quantify this, but I have included a few powerful quotes, one being, the younger the child, the smaller they are, and the less life they have lived. When asked about coping strategies, there were some themes raised, mainly communication, focus, and reflection. When asked opinion of debrief, 54% of the respondents thought debrief is very important. 27% stated this is important, but not particular to them. And 80% said it depended on an individual basis. This is evident that some people require formal debrief, but some people choose to do this in their own personal way rather than as a group. However, people should feel that they should be able to debrief when they so wish. Some suggestions from the respondents were debrief in whatever way possible, team support, and doubling up new team members if required. Remembering that organ donation saves lives and focusing on the recipient and mentioning this in the MDTs would be comforting. 3 respondents suggested that more pediatric exposure may be more motivating to see pediatric patients on the waiting list, but also to see post-transplant success. This survey has revealed pediatric organ retrieval is most emotionally challenging. I have seen a remarkable team spirit and resilience, but I feel that more is needed. Visits to Great Ormond Street Hospital and being doubled up as with an experienced member of staff has already been introduced by the senior management team. Moving forward, I hope to collaborate with other disciplines in pediatric organ donation to create and formalize a national strategy for emotional support and looking into external counselling as an option for those who may require this as well. In conclusion, I'd like to thank the authors and respondents for addressing their thoughts and feelings toward pediatric organ retrieval. And I hope to see this subject being explored more in the future and to support NOR's team members in the best way possible for their contribution to pediatric organ donation and transplant. Thank you.
Bianca. I don't see any questions from the audience. Are there any comments or questions from the panelists?
Well, just to give a comment, because we also do pediatric procurement and transplants. For us, it's the surgical team, of course. Organ procurement is not a fun sport. That's pretty clear. You have to work on that. People, there's always a very tragic story behind it, and you have to keep in mind that there are grieving parents who lose a child. Everybody who has children knows what this could mean to us. This is total tragedy, completely understood. So the good thing for us is that we're in close connection with our pediatric cardiologists. So we see a lot of the recipient side and keep in our heads, well, we're doing something good. And then we see the outcome of a happy child that's life is saved. But I completely agree. I think talking with each other inside the team, helping the team members to cope with that situation. And if nothing else works, external counseling, I think would be helpful. Just imagine that every professional driver in a car, when he has an accident or something happens, they receive counseling. Every policeman who has to shoot somebody in case of anything, they receive counseling. But in this situation where we're always between life and death, it's just nothing happens like that. I just discussed it with colleagues. If a patient dies in the hospital, in our hospital, you have to cope with that. It's even if you're the surgeon, that's part of our business, we know, but it's good to talk about this with somebody who understands. So I completely agree with what they said, similar, but we try in our team to talk with each other in these situations. So thanks for this great talk. Thanks.
Thank you.
Thanks. Any other comments or questions? Still cannot see anything in the from the auditorium. So thank you very much, Bianca. That's very interesting. And as Andreas is saying, there is always a tragedy behind a donor, however positive it is, the action, the act of donation. Thank you very much. So we're going to move on to the next presentation under the care of Tobias Adams, who is going to speak about outcomes of heart retransplantation, a single-center experience in the UK.
Good afternoon, everybody. My name is Tobias Adams, and I'm a fifth-year medical student at the University of Cambridge. This afternoon, I'm going to be talking to you about outcomes after heart retransplantation at a single UK centre. So over 5,500 heart transplants are undertaken annually, and the majority of units undertake between 10 and 19 transplants per year. Retransplantation, on the other hand, is a relatively rare surgical procedure, and as such, most units will have limited experience in heart retransplantation and will be unaware of the risks and benefits associated with the procedure. So between 120 and 140 cardiac retransplants are undertaken annually worldwide. Indications include primary graft dysfunction, cardiac allograft vasculopathy, and allograft failure. And research has shown a median survival of 8.2 years among redo transplant patients versus 11.6 years for first-time transplant recipients. So the aims of this current study are to compare short and long-term survival between those undergoing first-time heart transplantation and those undergoing redo transplantation. So this study is a single-centre observational study conducted at the Royal Papworth Hospital. It includes consecutive patients taken from January 1979 to September 2020 who underwent heart transplantation. Demographic and clinico-pathological baseline characteristics were obtained from the unit's database, and patients were then categorised according to whether it was their first heart transplant or a redo transplant. Then, demographics and clinico-pathological features were compared between the two groups. Kaplan-Meier estimates were generated to demonstrate the survival distributions of both groups, and these survival distributions were then compared using a log rank analysis. So, in total, 1,574 patients underwent heart transplantation during the study period, of whom 98% underwent their first heart transplantation and 2% underwent retransplantation. Of the 31 patients who underwent retransplantation, 12 underwent acute retransplantation during the same hospital admission as their first heart transplant, whereas 19 underwent retransplantation at a later admission. Overall, time to retransplantation ranged from 1 to 8,299 days, with a median time of 961.5 days. The results in this table show the mean age at transplant for the two patient groups, and the table then compares the mortality at 30 days and the estimated 10-year mortality post-transplant between the two groups. There was no significant difference in post-transplant survival at 30 days, nor at 10 years between the two groups. This figure shows the Kaplan-Meier product limit estimates of survival for the group of patients who underwent heart transplantation for the first time, which is demonstrated by the blue curve, and the group who underwent retransplantation, which is represented by the green line. The log rank test shows that there was no statistically significant difference in survival times between the two groups, with a p-value of 0.8. In conclusion, carefully selected patients may have reasonable short-term and long-term survival after heart retransplantation, and future work should examine the risk factors for early mortality after heart retransplantation, so that centres can then refine their selection of individuals who represent acceptable candidates for retransplantation. Thank you very much for listening.
So, one point or a comment. So, we also have our share of retransplants, but we completely stopped doing retransplants early after transplant. So due to primary graft dysfunction, we had very bad outcomes. And what we saw with the new technologies like ECMO support is bridge to recovery in graft dysfunction early after transplant, so these hearts recover. So we mainly focus now for retransplant on long-term patients with severe graft vasculopathy, where we just cannot do anything else, and they are still good candidates for retransplantation. Did you check at the difference between the time point when you did the retransplant, so early versus late retransplant? Did they have different outcomes?
Thank you very much for the question, Mr. Zucker. Can you hear me, by the way?
Yeah.
Thank you very much for the question. Due to the small sample size, because there were so few retransplants that were done in such a significant time period, we weren't able to do analysis based on whether they were done early or not. So however interesting that would have been to look at, it just wasn't possible.
Okay. Yes.
Okay, I think we move on. Mas, would you like to present Andreas?
Sure, with pleasure. Next presenter, Dr. Andreas Zuckerman, the keynote lecturer, VAD versus heart transplantation, heart failure, which is best for 2021 and beyond. Andreas.
Ladies and gentlemen, thank you very much for the invitation to the meeting, and I was asked to discuss VAD versus heart transplantation and heart failure, which is the best therapy for 21 and beyond. This is my disclosure slides. So the question is to find the balance between everybody should receive a heart transplant versus none, put all patients on a mechanically assisted device. So the biggest point is, what is the differences between mechanically assisted devices and cardiac transplantation? Well, with VATs, you have an unlimited number of devices, whereas in transplantation, you have like a for donor organs. With VATs, cost is dependent on the device, whereas in transplantation, the cost of a transplant is dependent on the procurement place and time and how you get to the procurement center. For VATs, it's a planned procedure, and in cardiac transplantation, you're always dependent on the donor offering. You never know when you have to go out for the transplant. It could be in the middle of the night. With VATs, you need anticoagulation, whereas in transplant, you need lifelong immunosuppression. In mechanically assisted devices, I think one of the Achilles heels is the driveline, which is outside of the body, and it's prone to problems, whereas the cardiac transplant, this is the mother of all VATs. It's a biological BiVAT, so it's the best biological, I think it's the real heart. But both of these therapies are associated with problems. In VATs, you have bleeding, right ventricular failure, infection, cerebrovascular accidents, and of course, special care of driveline infections. Whereas in cardiac transplantation, you can develop primary graft dysfunction, rejection, also infection, and the long run cancer and graft vasculopathy. The mechanically assisted devices short-term outcome is really good, whereas in cardiac transplantation, long-term outcome is very good. So the number of cardiac transplants is stable, a little bit increasing over the last years, and it's at about almost 6,000 transplantations a year, but still patients with heart failure is significantly more, so there is a clear need for more therapy on these patients. When you look at the survival in cardiac transplantation, this data by the ISHLT, you can see there has been a significant increase in survival over the last 20, 30 years. However, in the last period, 2010 to 2017, you can see this increase in survival has become only slightly better, and now 10-year survival averages around 50 to 60% in most of the centers. That technology really has changed, and it has revolutionized heart failure surgery. It has increased the numbers of VAT implants worldwide, and with the new VATs, these can support for a longer time. They have less technical problems and significantly less complications. So new mechanically assisted devices have less influence and almost no influence on post-transplant survival and complication. So the future focus is bridge the transplant or bridge the candidate versus destination therapy. So the question is this the future of end-stage heart failure, using pumps instead of cardiac transplants? So something like the rise of the machines. But when you look at the INTERMAX registry, and this is very recent data from the years 2015 to 2019, when you look at the BTT patients in the INTERMAX registry, after 1 year, 53% of them are alive and still on a device, about a third of them are transplanted, and 12% are dead. After 2 years, a third of them are still alive on an assist device, half of them are transplanted, and 16% are dead. Looking at the other group, destination patient, which is a really growing group of patients, you can see that after 1 year, around 3/4 of these patients are alive on a device, only 5% are transplanted, and 20% are dead. And after 2 years, about half of them is alive on a device, 11% transplanted, and 28% dead. So this is our routine American outcome data. At the ISHLT, there has been one of the newest studies, long-term outcomes from the Momentum 3 trial, presented also already has been accepted for the European Journal of Heart Failure. There you can see even improved survival with about 2 years of 83 to 89% of patients still alive on the device. In BTT patients and destination therapy patients, almost 80% of them are alive. So this really closes to 2-year outcome data in cardiac transplantation. Looking at the bridge to transplantation, about half of our transplant patients today are transplanted via mechanically assisted device. So this is a huge increase over the last 10, 15 years, definitely associated with this significant impact on better outcome with mechanically assisted devices. But a word of caution is that in the Eurotransplant area, when you look at the high urgent patients who have been put on the waiting list, on the high urgent waiting list in Eurotransplant, today almost 50% of them are VAD patients. So this means 50%, all of these patients have developed some VAD complications that are clear need to be transplanted pretty fast. So what is the outcome after transplantation if we are bridged with an assist device? Well, if we have a normal left ventricular assist device that is implanted today, well, the outcome is not different to those patients who have been transplanted from inotropic support or no inotropic support or no VAD support at all. The outcome of the first 3 years seems to be similar. Worse outcome are patients with temporary assist devices. This is pretty clear. But the question is, who benefits more of which therapy? And this is where we have to do some risk stratification with high risk or low risk for VAD and for transplant. So if a patient who has a low risk for mechanically assisted device, but a high risk for transplantation, definitely it's true we should implant the VAD. So one of these populations definitely are patients with secondary pulmonary hypertension due to heart failure, because it has been shown not only by IO, but also by others, that the implantation of a mechanically assisted devices really can decrease pulmonary pressures, pulmonary vascular resistance, and therefore patients can become transplant candidates and can be transplanted with an acceptable low risk. Next, patients with a high risk for a mechanically assisted device with a low risk for cardiac transplantation. Well, that's pretty clear. You should transplant these patients, and those are the patients really in need of biventricular support. And this is data from the IMAX registry. Again, the newest report. Those patients who really need simultaneous left and right ventricular assist device, they have a worse outcome. Those patients who are in need of post-implant right ventricular support, they also have significant, even a worse outcome than the other groups. Well, there have been some newer publications, temporary AVATs. This might help to spare permanent BIVATs. The early data seems promising, but we need to have more data on that. So what about those patients who have low risk for that, the low risk for transplant? But this is depending on the donor availability and the allocation of these patients. If you're lucky enough, this is European data, and you're living in Austria, Croatia, Slovenia, you might have a good chance to be transplanted in time. And this goes down over the different European countries, and they come to those countries who really have a low incidence of cardiac transplantation, a low transplantation rate, and unfortunately, the United Kingdom still is one of the lower ratings in cardiac transplantation. So definitely the patient with the same problems and the same urgent situation in Vienna will receive a heart earlier most of the times than a patient will be in London. But still, Eurotransplant has its problems. You can see the waiting list is increasing significantly, whereas the cardiac transplant numbers are stable. So what about the question about high-risk VAD patients and high-risk transplantation? Should we receive a VAD because it costs money, but it won't not waste a potential donor heart? Well, if you look at transplantation in high-risk patients like ITAMAX-1 patients, you can see, and this is based from a very good analysis from a Spanish registry, you can see these patients who have significantly worse outcome, higher rate of death, higher rate of renal replacement therapy, higher rate of primary graft dysfunction. The bad news is ITAMAX-1 is also an independent risk factor for death in VAD implantation. But nevertheless, when you look at the newest Intermax registry data, you can see that those patients in Intermax 1 over the last years, there seemed to be a slow rise, and again, about 70 to 20% of the patients in the Intermax registry are Intermax 1 patients. So this is quite an interesting change in the attitude when to implant a mechanical assist device. So the other question is, should we stay conservative in these high-risk patients, or should we do something like a bridge stabilization, short-term support, like with ECMO? And there has been some data published last year in the Journal of Heart and Lung Transplantation from the IMAX registry. Those patients who bridged to mechanically assist device with a temporary assist device, and you can see most of these patients have a similar outcome. Only ECMO-treated patients seem to have a worse outcome. Whereas if you look directly only in the Intermax 1 group, this difference between the groups seems to be less robust, and they seem to have similar or more similarity in the outcome. So we have also an experience like others have with ECMO bridge transplantation, and I do not want to get into the detail. The outcome in our patient population is quite well, but definitely this has to do with patient selection and very fast transplantation of these patients because they receive higher gen priority in the waiting list. The big problem is that these patients start to change in the position, so it's a moving target, and we really have to adapt in which position the patient seems to be. So there also have been new indications for cardiac transplantation, like a restricted disease, where we think the transplantation is the better option than mechanical assist device. The same goes with chronic congenital like failing Fontan. But on the other hand, patients with heart failure for chemotherapy and with previous cancer, I think if they have not survived 5 years after cancer was treated, I think that is the better option. The same goes with severe myocarditis because there might be a bridge to recovery in these patients. So the points to consider for decision: donor hearts available. This is dependent on the transplant law, the heart procurement rate and allocation rules. On the other hand, patient factors like the blood group. Blood group 0 has less chance to receive a donor heart. Size, weight of recipients, bigger patients wait longer, and also sensitization of the patients. But with all this perfect, great that data and that numbers, well, definitely there's also something like the Empire Strikes Back, like heart transplantations like that. So there has been also changes. There might be an increase in acceptance of donor organs. We have new ways of organ donation, like DCD heart transplantation, which is a huge and enormous experience here in the UK, especially driven by Cambridge. And we have new preservation technologies, the organ care system, new transport devices. So I think there is a very interesting future also for cardiac transplantation. So in summary, new generation for mechanical assist devices really have revolutionized heart failure therapy. Heart transplantation is still the best treatment option for long-term outcome, but this could change in the future based on the Memento 3 trial. Decision to transplant the support with the VAD is difficult and has to be re-evaluated regularly, so it's a moving target. A potential straightforward procedure, which is heart transplantation, is then converted into 2 procedures, VAD implant and then transplant, so it has an impact on cost but not on outcomes. Donor numbers and allocation rules mainly decide into treatment option. However, individualized decisions for patients are needed. New preservation technologies might influence donor acceptance rates and preservation success, and therefore might increase cardiac transplantation rates and increase outcome. So looking just in the future and giving you a little bit of science fiction, where xenotransplantation on the horizon, we might also move for ABM compatible in non-pediatric patients. And of course, in the very far future, we have something like DNA cellularization of potential donor hearts in 3D bioprinting. So in the end, I think transplantation really has a big future, the same as mechanical assist devices. So thank you very much for the invitation, and I'm very happy to answer any questions you may raise.
Thank you very much. Thank you very much, Andreas, for that fascinating presentation. And I guess just as a comment, as the new devices become better, the short-term outcome is proven to be challenging. The outcomes of transplantation, and I guess probably in the long term is where we're going to have to see what the best option is.
Yeah, in my opinion, still transplant in the end, on the long run, is the better option. You do not have a driveline. And patients, every time when we transplant them from a ward, they tell me, I'm so happy that I'm off this. I can swim now. But I know that it saved my life, but I'm really happy to be without this bulky thing around me. So they are thankful, but still we have to work on that technology. It has to be fully incorporated without a driveline, similar like a pacemaker or something
Absolutely.
like that. I think this is a very important point for the future, anticoagulation. So still, I think until I'm retired, transplantation will be still number one.
Absolutely.
Jorge and Andreas, are your centers involved in the Eberhard clinical trial?
Yes, we are.
Competence trial?
Yeah.
You are involved?
Yeah.
Have you started recruiting?
Yeah, we are. Yeah.
What do you think of it? Have you implanted any yet?
No, we haven't yet. We are recruiting, but we haven't yet implanted any.
Okay, so we'll see.
Okay.
Yeah. Still fun in the future.
I don't think it's the way in the future yet, but
yeah,
the way it looks
exactly.
like, but certainly. Yeah. All right.
Okay, I think we've had a fascinating session this afternoon here in the UK, probably still morning in the US. And I would like to thank, in name of the SCTS, on behalf of the SCTS, all the panelists that have joined me and the presenters for a great session.
Okay.
Thank you. Thank you very much, everybody.
Bye-bye.
All right.
See you.
Bye. Take care.
Yeah.